Hi, this is Elliot Fishman, and welcome to part 2 of the role of AI in the early detection of cancer. And we left off last time making the point that 40% of pancreatic tumors under 2 centimeters are missed on the original scans. And although we said that pancreatic staging is not necessarily only related to size, it's clear the smaller a tumor is, the more likely it's resectable. And if you can pick up stage 1 or stage 2 tumors, the survival rate is in the 60 to 70% range, not the 12% or 13% range we typically see these days. So it's amazing what pancreatic cancer and AI can do together. Earlier detection of tumors, that's what we're working hard on, and other people are working hard on. Better identification of tumors. So you see something, is it neuroendocrine? Is it going to be adenocarcinoma, an IPMN, a serous cystadenoma? Can we help with identification, so help with management? We've been doing a lot of work, and I'll show you some of it during this talk, on radiomics of neuroendocrine tumors, predicting whether to stage 1 or stage 2 and 3. Remember, stage 1 typically can be followed conservatively. We want to be able to do more accurate management of patients, knowing and putting together not only their imaging, but their lab values and a lot of the genetic markers, and coming up with a better strategy for management. It's been shown that AI can predict which chemotherapy might work better in a specific patient. Can we choose that? And then, of course, we're talking about new drug discovery. Pancreatic cancer does not have a Gleevec type drug, or a Keytruda type drug. We need something that will change everything, but we're looking for that, and AI is being used by many pharmaceutical companies, and hopefully that will help us discover a drug sooner than later. Just today I was reading an article where they're using AI to look at venom of snake bites and to be able to prevent patients with snake bites from dying. Worldwide, 100,000 people die a year from snake bites. They have published an article that basically shows that they have been able to come up with a medication that can prevent this from happening. So this will be very, very exciting. There are a number of different articles looking at AI and the pancreas. AI has the potential to aid in the early detection of pancreatic cancer by analyzing medical data and identifying patterns that may indicate the presence of the disease. Deep learning techniques can be trained on large data sets to accurately identify early-stage pancreatic cancer. So, of course, one of the things we're working on is not just picking up size as a criteria for early detection, but can we look at textural changes? Can we look at ductal changes? Can we integrate also the patient's history? Can we use things like a bridge where you can really challenge the medical record to give you information? And again, although we're radiologists, we know that for things to work really well, and this is why AI is so exciting, the integration of radiology, medical records, clinical history, family history, putting it all together to help us define and detect disease early. AI can serve as a powerful tool in the advancement of pancreatic cancer diagnosis, management, and prognosis. Okay? Every step of the way, AI can potentially help us. So this is indeed very, very exciting. Trapani also goes on, challenges we have. We need better and larger data sets. Hopkins now we have about 15,000 patients. We've segmented over 4,000 adenocarcinomas, numerous neuroendocrine tumors, over 1,000, IPMNs, normals, but we need more. One of the things that AI can do better is be trained with bigger models. So if you have 20,000 pancreatic cancers, all different appearances, size, locations, how the gland looks, all of those things will help us make better decisions and come up with better algorithms. Again, one of the challenges AI faces, and it's not just with pancreatic cancer, but it's in all of medicine, is you need adequate data sets, okay? We need to be able to figure out ways to share data, Some people suggest now maybe patients should be allowed to donate data. That may get around institutions that don't want to share. Or, at the end of the day, perhaps institutions will share better if the NIH or different donors say, listen, if you don't share, we're not giving you money. That can be a very strong process. Pancreatic cancer is a complicated disease. We need to integrate all the information from genomics, transcriptomics, proteomics, metabolic omics. You need every omic you could think of to put together to really help us find signatures that will allow us to have early detection. And just to make the point that radiologists know, we talk about small lesions being missed. There was a good article last year by Satomi Kawamoto on missing things in clear sight, but we talk about things that are missed. They're small, isoattenuating, and don't change the contour of some of the problems. Here's a good example where the initial CT scan, it was done for hematuria. So again, the importance of always looking at the pancreas. There's a very subtle finding you can see up here and here that a few months later, 9 months later to be exact, has now increased in size, and now there's vessel involvement, and the patient would not be resectable. Again, it's only a few months, but those few months can make all the difference in the world. Or in this case, we talk about pancreatic duct dilatation. The number one reason tumors are missed in many series is that people see a pancreatic duct a little bit prominent. Either they ignore it or they just comment on it without forcing and pushing on the significance of getting additional studies or careful follow-up. Pancreatic duct dilatation is one of the most important things we'll see. It just doesn't happen normally. Yes, you can get a pancreatic duct and it can be narrowed in chronic pancreatitis, but you got to make sure you're not dealing with pancreatic cancer, okay? We need to look carefully for duct cutoff and duct dilatation. Here's a good example, top row, of a mildly dilated pancreatic duct, and you don't see an obvious mass, but if you look hard, maybe there's some changes. But here it is just 4 months later. Look how much larger the tumor is, and look at how much more obvious the tumor is. This is not a technical difference. This is a real difference. Pancreatic cancer can evolve very quickly, and in order for us to really do a good job with our patients, we need to pick up things earlier and earlier. We've also learned by looking carefully at scans that were done pre-diagnosis that there are findings on CT that we often don't think about, but can be a really good early sign of pancreatic cancer. Between 1.8 and 4.6 years before diagnosis, you may see focal atrophy in the gland. 3 years or so before diagnosis, you may see some fibrosis with faint hyperenhancement in the gland. No mass, but subtle hyperenhancement. And a little over a year before diagnosis, you may see that pancreatic duct dilated with cutoff. You got to be paying attention because these are the signs that allow you to make early diagnosis. This focal atrophy is very interesting. I never really thought about it. We always did think, well, if the gland is atrophic distally, you better look carefully. But focal atrophy in the gland, yes, it can be due to trauma or theoretically pancreatitis, but if you see it without a history, you got to be really careful to follow that patient because that may be the best sign of early pancreatic cancer. We also need to think about pancreatic cancer as a volume. We talk about cinematic rendering, looking at texture and not masses, and that becomes very important. Just a few simple examples. Here's a subtle mass that's often missed, about a centimeter or so, in the patient's pancreatic head. That's a carcinoma that would be resectable. Here it is on the cinematic rendering. We are looking at the textural changes in the pancreatic head, nicely seen, and especially nicely seen in the coronal cinematic 3D views. We're looking at textural changes to pick up masses that can easily be overlooked. Or in this case, you see a dilated pancreatic duct which stops. That alone should make you worry. But if you look at it a bit more carefully, On the cinematic rendering, you could see the textural changes in the gland, which mean the patient has a tumor present there. Again, cinematic rendering is a way of post-processing and rethinking about the data. Here's that prior case, again, nicely showing you the duct accentuated and the textural change here compared to the gland here. This is where the tumor is. So what you really need to be thinking about is every step of the way, not just looking at the axials or even coronal images, but looking at things in a volume with 3D, and not just any 3D. MIP is great for looking at the vessels, but cinematic rendering for looking at the texture and trying to pick up early tumors. And we've written about this. Cinematic rendering can accentuate subtle texture changes and improve tumor conspicuity relative to traditional 2D maps, and even volume rendering, and of course, due to MIP. So this can potentially improve the assessment of resectability and assist in determining vascular reconstruction options. So not only is it early detection, but it can help us with managing the patient. In this other article talking about surgical planning, this is with Chris Wolfgang, Javad, and their team at NYU now, the ability of looking at cinematic rendering and helping with vascular mapping to predict resectability. The next thing we need to think about, okay, now we're saying we look at the images and we look at them with cinematic rendering to look at it better. But what if we make the point that there's so much information in the image that even if we spent a lot of time just staring at the images, we're not going to see? And that's where radiomics comes in. And radiomics is a very exciting part of what we can do, we are doing, and will be a big part going forward in medical imaging in pancreatic cancer, but across many different cancers. Radiomics refers to the extraction of mineable high-dimensional data from radiographic images and has been applied within oncology to improve diagnosis, as well as prognostication within the realm and with the aim of delivering precision medicine. The premise is that imaging data conveys meaningful information about biology, behavior, and pathophysiology, and may reveal information that is not otherwise apparent. Now, what is radiomics? What you're doing is you're looking at a CT scan and thinking about the O's and 1's that make up the image. We can see a lot of those changes, but it's really when you provide different filters, different algorithms where you could accentuate and detect what's going on inside the pancreas or any organ. We look at shape, we look at first-order features, we look at image texture, we look at many different filters, and there are many different ways we can look. There's probably 50 or 100,000 different algorithms you can use, but typically we'll start off looking at thousands and get down to about 10, which become the ones we use for a specific problem. Radiomics provides a more adequate and reproducible measurement of the tumor than other methods. That becomes indeed very important. So when you look at the pancreas, we first have to segment out the pancreas. That's an important part, and why that needs to be, machine done, not have us, the radiologist, technologist, or someone else do it. The computer needs to do it because that's how we're going to look at millions of patients. We then look at things like shape of the gland, focus on things like atrophy, duct dilatation, any changes in shape. We'll run different filters, particularly random forest classification, and we look and predict what information we can get, whether you're running first-order statistics or second-order statistics, whether we're analyzing the raw data, clustering the data, changing different parameters. All of that is within the realm of what we want to be doing and need to be doing. And when we did this, we published this article a few years ago comparing pancreatic adenocarcinomas to normal glands. What we found was the normal gland has a signature, and the signature is different than pancreatic cancer. And so our accuracy in distinguishing using 40 features was nearly 99%. So you could imagine, look at a pancreatic gland, think about screening. Can you screen and pick up who has cancer and who doesn't? And again, this idea about converting data into high-dimensional features, it's really what's most critical. Texture features are calculated in 3 dimensions, considering the correlation of signal intensities of adjacent voxels. In addition, feature extraction may be performed after applying a secondary filter, such as a wavelength or Gaussian filter. So again, putting all of this together, there's also been articles making the point that you could look at radiomics to predict whether the nodes are involved. Patients who recur, patients who don't do well, it's often because nodes are positive. And you want to be able to predict when you have positive nodes because those patients really need the most chemotherapy before you operate on them. So imagine a non-invasive tool which can predict which patients' nodes are positive. This article by Wang makes the point. Radiomics, also referred to as whole tumor virtual biopsy technique, enables the extraction of numerous features from the entire tumor, reflecting its heterogeneity and characteristics. A biopsy examines only a portion of the tumor tissue, which cannot comprehensively assess the intra-tumor heterogeneity before surgery. In contrast, radiomics can non-invasively reflect comprehensive information about the entire tumor. So now what you see what we're looking at, and we talked about this a few moments back about neuroendocrine tumors, biopsies only have limited tissue, and they're very good and highly accurate, but there's variation by 10% or more, and often they don't make the diagnosis. But radiomics perhaps can give us all this information because it's basically non-destructive testing for looking at pancreatic tissue. In this article talking about, which we wrote, talking about cystic neoplasms and comparing how well the computer does predicting what a tumor is, what type of cystic lesion is comparing to radiologists, we're able to show that the computer, the radiomics program, was more accurate than experienced academic radiologists. So again, improved diagnostic accuracy can maximize the efficiency of healthcare utilization by choosing and deciding how to manage individual patients. We talk about grading. I mentioned the importance of grading, but again, you do a biopsy, you have a limited specimen. CT is well in the high 90s with radiomics for determining grade 1 versus grade 2 and 3 neuroendocrine tumors. Grade 2 and 3 you're definitely going to operate on. Grade 1 you're going to follow. So that becomes very important in terms of managing these patients. And so there's an article by Javad. This non-invasive tool can help in assessment of grade at diagnosis to determine need for resection, as well as serial assessment of patients on surveillance to identify potential changes in tumor biology. So now think about it. We're using CT with radiomics, of course, to look at tumor biology. So the applications really are too long to list, but you could put them into detection categories, classification of tumors, and prognosis. Again, put it all together, we're talking about personalized medicine. In this article by Wang talking about CT radiomics of the pancreas, comparing healthy individuals and cancer, CT-based radiomics analysis based on the whole pancreas can distinguish pancreatic cancers from healthy individuals and potentially become early detection tool. And again, with pancreatic cancer, we know that the earlier we can detect a tumor, the better the outcome. And this is true literally with every tumor, quite frankly. Chemotherapy works better, immunotherapy works better when tumors are lower grade and when tumors are smaller. And you got to take it to another step. And I think maybe because of time, we'll stop here. But if CT is so good with radiomics at detecting early tumors, can we detect tumors years earlier? What if you did that? What if you had the scans that were done before diagnosis, a year or 2 or 3, often when there was no concern for pancreatic cancer? And if you looked at radiomics, can you predict these pre-diagnostic scans? And this article from Mayo Clinic, they looked at pancreatic cancer patients where they had scans 1 to 3 years or 4 years earlier because they may have had scans for trauma, hematuria, many different reasons. But they found that looking at those pre-diagnostic scans, they were often able to find the tumors, and the radiologist never read them. But even in retrospect, knowing there was a tumor present, the radiologist couldn't find them. So now we're talking about detecting pancreatic cancer before it's visible, even if you know it's there. And this was 2 good articles that were published, and this review by Michael Rosenthal. Machine learning-based radiomic analysis may be a novel strategy to screen for pancreatic cancer by revealing changes in the pancreas that precedes the development of pancreatic cancer and the emergence of a radiological detectable mass. We are relying on masses, and we're working hard to pick up smaller and smaller masses. But what if I didn't even need a mass? That's where radiomics can become very important. So I have a little bit more to talk about radiomics, but let me stop here. Let's come back in a few minutes and pick it off right from here. And with that, see you in a few minutes. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.